Okay, guys, this is the last class for Special Pops 1. And it's interesting that the last class is the one that most students kind of experience throughout the semester. Anyway, we're going to be talking about crisis, anxiety disorders, PTSD, OCD, phobias, and caregiver role strain. I have changed the PowerPoint from last semester, so I wanted to let everyone know that. Excuse me. I always get a frog in my throat when I lecture lately. Okay, the SLOs differentiate between the 4 levels of anxiety according to clinical manifestations. As the physiological and psychological stressors and the reactions to the stressors increase, the more hands-on the healthcare provider, the nurse, will be in helping them get that anxiety to a level where they can deal with it effectively on their own. All right, 2, discriminate among the 2 basic types of crises. Always think of maturational and situational type of crises. One as a result of the stressors going through a developmental level, having developmental crises, things that you need to deal with in order to grow and develop. Also, situational could be those things personal, loss of a job, for instance, and also acts of violence that can happen to someone. We'll get into more of that later on. Discuss the phases of crisis. Be aware that the person tries to deal with the crisis. Do y'all remember the defense mechanisms in the communication lecture? These are some of the things that patients will use, and we need to acknowledge them when we see them. Differentiate the nursing approaches utilized when interacting with individuals experiencing anxiety or crisis-related disorders. A crisis is more growth promoting, getting through a crisis and coping with it effectively means that there's high likelihood a person would do well with experiencing other crises in their life. And 5, discuss the effects on families, caregivers, and significant others in caring for individuals with severe and persistent mental disorders. It's not just the psychiatric disorders, it's families dealing with their loved ones that have illnesses that can be lifelong or can be long-term, and how we as nurses need to shore up their coping and also make sure that they take care of themselves so that they're able to take care of their ill loved one. Okay, crisis. Crisis is the experience based on an event or a situation that overwhelms the ability to resolve or manage the event or the situation through normal coping. So there is a state of disequilibrium. Everyone experiences crises. I bet you some of our students have experienced some crises in their life, and as a result have learned, have grown. They usually resolve within 4 to 6 weeks, so they're very time limited. And the outcome, what we want, is that the individual gets to a pre-crisis level of functioning. What was it that just tipped them over and to go into a full-blown crisis? And what can we do to help them get back to that prior level of functioning? The experience itself is not pathological. We go through life having crises, some more than others, but it represents a struggle with the equilibrium, and an adjustment needs to be made when problems seem unsolvable. So you as a friend, you as a caregiver, you as the nurse will experience in this in your nursing career, and you will be present with patients and help them get over this hurdle. Did somebody say something? I thought I heard something. We need to view the crisis from the eyes of the patient, not how we interpret that crisis. So we need to be present for them as they experience the signs and symptoms that they have with anxiety in dealing with the crisis. And their interventions need to be broad, creative, and flexible. So we're going to get into how have they coped with similar things in the past? Did it work well for them? Did it not? Are they willing to look at other coping strategies that might help them in dealing with the crisis? So we kind of lumped crises and anxiety kind of together as far as nursing care. All right, let's look at the type of crises. The first one is maturational or developmental. I'm more familiar with Erikson's stages of growth and development, and we have certain milestones, which in some respects is like a crisis that they need to master that before they can move on to the next developmental level. And some of those growth and development stages in Erikson is trust versus mistrust. You know, that baby needs to know that there is a comforting person that is there for their personal needs. And think of the person with postpartum depression that, sometimes that mother cannot connect with that baby. They cannot bond with that baby. And hopefully another surrogate will come in and take care of the needs of the baby while the mom is getting treatment. All right. And then, so you can always look out for potential crises as individuals go through growth and development. And then situational crises are those unexpected events that occur in someone's life. Now, if you have an older edition of Pearson, Pearson divided it up into 3 different types of crises. You're responsible for the 2 types. They lumped the one that was disaster related into situational, because really it's just things that happen in people's lives that they possibly can get them into turmoil, such as a personal issues, such as a divorce, or issues with school, or COVID. Let's put that in there too. You know, how did that deal with your family? Disasters, floods, hurricanes, fires, tornadoes, terror attacks, airplane crashes. They just happen. And violent crime, or being part of violence. And think of the adolescent who is bullying to the point where they actually commit suicide because they think that's the only plausible thing that they can do. And hopefully the school nurse peers in their class will help them with that. All right, the phases of a crisis. All right, the first phase is that someone becomes aware that there is a problem that is, and that they need to deal with it. It threatens their self-concept, so it becomes more and more of an issue. You see the intensity increasing with these phases. They try to problem solve, but for whatever reason, their problem solving is not working. They have higher anxiety, and it can lead to a panic state. And y'all learned a little bit about fight or flight in level 1. So does someone fight, or do they succumb to that problem, or how that problem affects themselves? And a lot of times at that stage, it could be that the stress is so overwhelming that they succumb to an illness. And I know you've had some readings in that at level 1, which eventually ends up being a crisis where that person probably needs some outside intervention. All right, with crisis intervention, you could have been a good friend to someone to help them through a crisis. Crisis intervention is what we do to assist those in how to cope. And our interventions, like I said before, were very flexible based on their needs, their perception, what resources they have. All right, anxiety disorders. Now, you know through this course that you can have one mental disorder. You can have anxiety and depression. You can have schizophrenia and depression. So we can have more than one disease that we are dealing with. First one is generalized anxiety disorder. And they think there's an issue with the neurotransmitters. And from my readings, it seems like it's that GABA, the GABA receptor sites, which we can use as far as medication to help get people to a calmer state. We know it runs in families. Mom's got it. Probably one of the children also has bouts of anxiety. All right, generalized anxiety disorder can be chronic and excessive, intense, exaggerated tension, worry, and anxiety more days than not for at least 6 months. Look at the intensity of these descriptors I have up here. Intense, exaggerated, chronic worrying, always thinking the worst. Usually they have cognitive distortions. They see things all black, all white, or that something happens and they think the worst thing. Symptoms: persistent worrying that is out of proportion to the circumstances, even though we need to look at the anxiety disorder through the eyes of the patient. That you can't stop. They worry about relationship, bills, health, children, husband, wife. Overthinking or overreacting to situations. Fear of uncertainty. And they startle very easily. You could see how people would have problems doing their job and taking care of their family if they so preoccupied. Problem sleeping. What happens with lack of sleep? It also sets them up for other health problems. They're very indecisive and they have problems concentrating. What does some of this look like, guys? It looks like mood disorders, doesn't it? Some of these vague type things that are going on with people. And we need to tease out what exactly is happening to our patient. Physiological symptoms, muscle tension. You know, sometimes patients might not realize that they're so tense, and that sometimes by doing some progressive muscle relaxation, they start to realize, you know, I have all this tension inside my body. Headaches, difficulty breathing, fatigue, nausea, diarrhea, and chest pain. Those are just some of the symptoms you would see with someone who has a generalized anxiety disorder. PTSD. This is when a person has suffered some type of traumatic event, and we always think of it as combat, being in the war, that kind of thing, but it could be a terrible accident or witnessing of an accident or a terrible event in the community, and that they have vivid flashbacks and fear, and they're so scared that they kind of shut down. They have social withdrawal, helplessness, or they're very hypervigilant, or they may even have survivor guilt. Why was I the only one that made it through that terrible accident where everybody else in that car has died? These symptoms usually begin within 3 months after the traumatic incident. I worked very part-time with a rehab company, and they gave me a case of a woman who they wanted to label as PTSD. The other nurses at that facility were thinking she was faking it. But as I got to talk with her, she talked about falling in a very large hole late at night after getting off her job, 3 to 11. And she said she stayed in that hole for about an hour because there was nobody in the parking lot that would realize, that she was in distress. And I could see something like that happening, and being alone and the anxiety just increasing and increasing, that I think she was really showing PTSD symptoms because she had flashbacks over and over again about the situation she was in. Symptoms usually begin within 3 months after the traumatic incident. Excuse me, guys. All right, OCD, obsessive compulsive thoughts, uncontrollable thoughts, impulses or images that cannot be dismissed from the mind, thinking over and over and over again. And then the ritualistic behavior that they feel like they have to do over and over to reduce the anxiety. Excessive cleaning, washing, arranging things, checking on things. How many of y'all checked the front door and make sure you didn't put the key, took the keys out of the front door? How many of y'all going back into the house, making sure that the stove is off? Excessive preoccupation with security or money, repetitive body movements, eye blinking, head nodding, clearing throat. Some of the physical symptoms that you might see, or people with eating disorders may be dealing with an OCD episode. Panic disorders or panic attacks. The physiological effects that happen when something jaws your equilibrium, pounding of the heart, feel like your heart is about ready to come out of the chest, sweating, fainting, nausea, breathlessness, fear of death, or losing control. With panic disorders, they're usually the most treatable disorders. They would put these individuals on an anti-anxiety medication, but eventually they'll be switching them over to an antidepressant. Remember that with anti-anxiety disorders, you can get dependent upon these. And if you have a patient that's been on anti-anxiety agents for a long period of time, remember, when they want to get off, they have to wean that drug down slowly because they can have a rebound effect. Phobias. I'll tell you my phobia. It's snakes. I can't stand snakes. I almost freak out, freeze in front of a snake. And I was constantly worried about that when I was up in rural St. Tammany in Mississippi, thinking that there was a snake. And yeah, snakes are out in the rural areas, Persistent irrational fears of a specific object, activity, or situation leading to avoiding the object or the situation. And yes, this is a specific therapy that this individual needs to get. They slowly need to desensitize these people. How many of y'all are fearful of going in an elevator? I worked with somebody who used to walk up 18 flights of stairs so that she didn't have to take that elevator. And she would leave about 15 minutes before it was time to end so she could go down those stairs. And she wasn't no young person. She was getting up there, you know. Agoraphobia. How many of y'all don't like to talk in public? How many of y'all don't like open spaces? Claustrophobia. We talked about elevators, dogs, flying bugs. You're living in the wrong area of Louisiana if you don't like bugs. We got bugs like crazy, flying insects and strange, very strange bugs. And social phobia. We talked about social phobia. I'm going to stop here. Does anybody want to bring up anything about their phobias, or you know of a situation with someone else? You can maintain confidentiality and talk about maybe someone else's phobias and how debilitating it can be for that individual.
My mother-in-law doesn't, she doesn't like windows.
Window.
And she had to have, like, if we go into our house or when she was staying with me after Katrina, everything had to be closed off, the windows, not a peek of sunlight, she never opened the windows. And I was like, I couldn't understand that. And it was like, let the sunshine in. She was like, close that windows, close that window. If it's to the street, because my house, some windows are to the street of my house. And then even to the backyard, she liked to close all the windows.
Uh-huh.
And
that was an issue after Katrina because, you know, a lot of people didn't have electricity. We didn't have air conditioning or anything. And then here you are closing windows and closing curtains and getting it even darker in there, could probably leading to more bouts of depression or, you know, dysthymia, you know. Yeah, that must have been hard for you, you know. Didn't have lights. Anybody else? Thank you, Michelle.
you're welcome.
I've got a weird one, but I'm actually terrified of jellyfish.
I would be too, because they sting and it hurts.
Well, it stems from when I was really young, running out into, I think, the Gulf after like my dad and my uncle, and I ran into a whole swarm of them, and I basically passed out from it in the middle of the ocean. And like ever since then, I just don't go in the ocean anymore.
Wow. Thank you. Anybody else? Wesley, thank you. I know there are more of and
So I'll tell you one of my personal, it's not anymore, but when I was pregnant with my son, I did not like to take the elevator. I had like this fear that like I would be like 9 months pregnant, the elevator would break, I would be delivering my child in an elevator. Now I didn't have that fear before I got pregnant. I don't have it anymore, but that was like my biggest fear when I was pregnant, was to be stuck in an elevator.
First baby?
Yes.
First baby. Well, I would think you would have issues because of the unknown, you know?
Yeah. I mean, it wasn't a fear before, and it's fine now, but like especially when I was like 7, 8 months pregnant, I did not like being in an elevator. I don't know what it was. I just felt like just scared to be in an elevator.
Okay, thank you. All right, guys, we're moving on, unless anybody else needs to share. We already talked about behavior modification, and we've already talked about the use of defense mechanisms. Let them do what they need to do to decrease the anxiety, and a professional will help them desensitize them to the situation. All right, I changed this PowerPoint because I got an evaluation from a student saying that I did not address nursing care for patients experiencing anxiety and crisis. And so I wanted to make that more pronounced. So I put the disorders first and the nursing care at the bottom of the PowerPoint. Now, be aware that therapeutic communication is the biggest thing. Being present for our patients and helping them decrease their anxiety when they're experiencing these disorders is best. Also, along with making sure that they take their medicine or that we look for side effects associated with these medicines. And hopefully they're not on it long term. I have a friend who has bouts of anxiety, mainly focused on her children as a result of them being on their own, and she's not available for them. But, you know, the issue is she having some issues with letting her adult children go and become more independent too. What I might be talking about? Isn't there a developmental stage that moms and dads, especially moms, I think, but men, help me out with this one. You know, it's hard to let go of the apron strings. Anybody want to
You talking
share?
about the umbilical cord syndrome?
I don't know. I never heard that, but I guess it is.
Yeah.
You know?
My husband had that with his mama.
His
He
mom?
can't let go.
Okay.
He can't let go. She can. He can't.
Oh, okay. All right. Well, you know, you really need to know the history, what is going on with that patient. Okay, so the focus is on therapeutic communication, guy. Identify the situations that produce the anxiety and or the crisis. Develop realistic coping strategies to help them deal with it. You know, we want them to get to the point to acknowledge that they're having these anxiety related signs and symptoms and that they can implement some coping strategy, and we are there to help them as far as you know, helping them with deep breathing, having more focused interventions and actually doing the coping strategy with them as far as counting or deep breathing or, you know, whatever they do, visual imagery and other stress management type of techniques. We need to be the advocate for the patient, and we need to be aware when they are using those defense mechanisms and look at whether or not they're being helpful for them. All right, what I want to say here. We need to assess the level of anxiety, and we have another slide shortly that's going to talk about the 4 levels of anxiety. We need to look for the cues that the patient is experiencing, vital signs. If y'all remember, in those case studies for Special POPS 1, we had patients that had changes, elevation of pulse and respirations on those case studies. And, you know, it wasn't very high, but still it was present, and you could possibly assume that that patient was experiencing stress because of the relapse that they were having. Explore the perceptions, how they view that anxiety producing event. You know, what were the circumstances? Do they remember what was happening before they actually got into that full-blown anxiety attack? And what were their emotional responses when that event happened? And I always want to emphasize that we need to look at this through the eyes of the patient. We need to gain information and to see how the patient perceives things and how they try, if they even acknowledge that they can see what is happening to their body, and how are they coping with this. All right, just as a review, some factors we need to consider are the perception, the pre-existence of prior anxiety attacks, or their how well are they physiologically and emotionally? Do they have issues with mental health disorders? You can have an anxiety disorder on top of a substance abuse or schizophrenia or anything, co-occurring disorders. You also going to have experiences with patients in the med-surg setting going through periods of anxiety or crisis. What about that individual when they find out that they have cancer, that they have lost their baby, that they have a health condition that is going to be chronic and progressive, that they may lose their eyesight? You know, you're gonna have patients, and you're gonna have family too that you're dealing with, based on circumstances of why they're in the hospital. Their level of coping, and let's put developmental level together. You know, little children really don't have a nice repertoire of coping strategies that they can use, and so they may act out, which is very inappropriate. Remember, we talked about regression in that sibling when the newborn baby is born, you know, that they may act out. They may, and it may be because of their anxiety of having this new person that has all the focus of attention, and that here they are, and they may regress back to diapers, back to using a bottle and things like that. Know that is normal, and that will change. As we get older, we can cope a little better with losses that happen in our life. Think about the elderly person that has those ongoing losses. You know, is that part of life? Will they be able to deal with that? And the level of support, your peers, your families, your significant others, your co-workers, groups that are in the community that can support you. AA, Alcoholics Anonymous, if that's the kind of support. Remember, a lot of times, well, it's been my experience when people would share with me what was going on and why they started drinking or using again. It was because that life got to be so unbearable, and that's how they coped. And that's not necessarily the best way. And so, and they're dealing with loss, or they're dealing with depression. So support, level of support. As you get older, you have more and more support, don't you think? As opposed to that little child trying to struggle with what's happening in their life. All right, this is the level of anxiety, and you know, this is a good test question, guys. As anxiety increases, the more the patient's safety is at risk, and the more the focus of care is very individualized. You know, mild anxiety, increased alertness, awareness, auditory and visual perception is intact, and they're able to problem solve. I would think at this point, students and myself, based on circumstances, would have a mild anxiety. And I think you were already taught that a little anxiety is good because you focus your attention on what is important. Y'all have a lot of tests coming up. Do y'all feel a heightened sense of anxiety as a result of the semester ending?
100%, yes.
Yes, okay. And, you know, as faculty, we like you at a little mild anxiety because that means you're more attentive. You're able to get the information It's a shame, but it's better than someone who may be listening to class and falling asleep. I don't know how much they're going to remember about that class, but anyway, mild anxiety. So if I had a test question on mild anxiety, you could just kind of relate to yourselves right now, right? Yes? Moderate anxiety. So we're going up the scale of anxiety. Selective inattention. You may be getting the key points, but you're missing some things that might be said in class. Or you don't realize that something else is going on in your life because you're so focused on one thing. You're focused on relevant information. This is what I got to do today. This is what I got to do tomorrow. This is the test next Monday, and then I have another one the next Monday. You may feel some muscle tension, and you may see some sweating. Some physiological ways of releasing that tension would be helpful to someone, such as some physical activity, going out, take a walk, run. Well, we got something going on. So moderate anxiety. Okay. So maybe your teaching might be more structured, maybe use some cues and nonverbal behavior to help that person understand what the teaching is about. Okay, so yeah, they can problem solve. They may need a little direction, you may need to see how much they retained and maybe state it again, Severe anxiety. Now we're going up, guys. The person is focused just on fragmented details, doesn't see the big picture here. And you have a more physiological symptoms, nausea, headache, dizziness. They may not be able to see the connections between details and have poor recall. So you could see that teaching might be more impaired with severe anxiety. And your nursing care may need to focus more so on repeating information and maybe doing the teaching over a period of time. Okay, the panic level is that they don't even notice their surroundings. They have a feeling of terror and they can't cope or problem solve with anything. And this is where the nurse, the healthcare provider, has to be more focused, working with that patient, being in the trenches, I say, to help them. You got to get that level of anxiety down. And so you may do coping strategies with them as you helping to decrease that panic stage. Help them with progressive muscle relaxation, deep breathing exercises. Do you know that when you deep breathe, that it forces the heart rate to go down by doing that? So help, and do it with them, be as nonverbal as possible because they really are in a high anxiety state. All right, let's move on. Any questions with that? We want to get someone to a pre-anxiety, pre-crisis level as soon as possible for them. Work with them. Be therapeutic. Use those open-ended communication techniques. That's the only way you're going to see how that patient is experiencing that crisis or the anxiety they're experiencing. Okay, consider previous level and effectiveness of coping with the challenge that they have. And here's an example. In the past, what have you done to feel better and or cope with the difficult situations? Have you used these ways of coping for this situation? Have they worked? Have they not worked? What other ways have you coped? It is best to use something that has been successful with these people in the past.
Dr.
Now,
Hoppy, I have a question.
yes.
So if the patient's in a state of panic, though, talking to them wouldn't be effective at all. Like
Well,
while
you're
they're
going to
panicking.
be talking with them and using some kind of strategy to get that anxiety down.
Okay.
Jerry,
You can talk to them because I sit with patients at the hospital. Like when they're in that panic mode, you just have to kind of bring yourself down to their level. Like you just have to make eye contact with them and kind of say, okay, take a deep breath, sit down for a minute. And usually they're gonna sit down and they're gonna calm down. If not, then they can come in and take care of it.
mm-hmm. Yeah, I would try some kind of strategy before I would give medication. But, you might need to resort to medication. Who was that was talking? Thank you.
Teresa.
Teresa. Okay, thanks, Teresa. Now, there are some things that if you know that anxiety increases, you might physiologically do things to help you with that. And we've talked about running and walking and being active, get those endorphins running. You can cut or eliminate caffeine, alcohol, and smoking. Some people smoke because of the stressors they have, which is kind of maladaptive, since smoking can cause many health problems down the line. Coping strategy and behavior modification techniques. Here's some I already talked about. Going to get a massage. Sometimes just getting your toes painted or I don't know, just going out and having lunch with friends can help with that. And also you have your support system there and hopefully you can share what's going on with them. Counting back to from 10 and being mindful, being present about how you feel, how your body feels, how tense you are. What is going on? How are you thinking? How are you feeling? How are you behaving because of this circumstance that you're in? I think I talked about the last one. Consider developmental and ability to cope and using a bunch of different coping strategies to help. How you think cognitive behavioral approaches are very big in helping people deal with anxiety. All right. Intervention, develop a plan. Here we go. Communication, very important. Be non-judgmental. Allow them to talk about their feelings. Make sure you're not using any closed-ended therapeutic ways of communicating. Stay away from why, what, where, when, where, and things like that. You got to have some plan in place when these things happen to them. We already talked about the anti-anxiety, the antidepressants, and the antipsychotics if necessary. Let's see if I need to bring up anything more with that. So, as far as the short-term goal is that we need to, they need to be aware of those behaviors they have to indicate to them that the anxiety is increasing, and they need to be able to talk about some strategies that they can do to help them in that situation. I think I've already talked about the rest of the slide. Oh, where did I go? Maybe we need to stop here and talk about what some students might do that they find is very helpful to them as far as dealing with increased anxiety. I'll share something that happened with me when I was about ready to defend my dissertation. I went to my major professor and we talked, and all of a sudden she asked, why did I change my whole presentation? I thought I did a good job. She didn't like it. She wanted me to go back to my previous version that I had. And at that point, I just freaked out. I freaked out. I totally shut down. It was a day before I had to get up in front of a group of people, professionals, and discuss and defend my research that I did. And so I remember coming back to my office at Charity and just staring at the computer. And somebody came and realized I was in bad shape. And so a whole bunch of resources came to my defense. The audiovisual department, the computer tech guy, I had other faculty, and even my husband at the time knew that I was freaking out. And he said, don't worry about the kids. I'm taking them. We're going somewhere. You're going to have the whole evening to yourself so you can regroup and get yourself ready for the next day. So that fake it till you make it. I know some of y'all used that before. Well, that's what I was doing. I was faking things until eventually this was all over. I got to the point where I said, I can't do any more. I have to go with what I have, and I did. And so, yes, I graduated. They approved my dissertation. They didn't realize I went through all that the day before, but my support group really helped me through it. And then your self-talk too. Do y'all use self-talk? And get to the point, hey, this is it. I'm going with it. And, if they don't like it, well, I'll deal with it when that comes, Does anybody want to share anything about what they do when they get into bouts of increased levels of anxiety? Mine was very limited, but you could see some people may have to stay in that crisis state for a much longer period of time, and they really need the support. Anybody?
I find like whenever I get in like not panic states, but yeah, like minor crises, I have to get it out of my head. I have to talk about it with someone.
Mm-hmm.
I do deep breathing and yoga sometimes, but mostly like the most helpful is like talking about it with someone.
Mm-hmm. Mm-hmm. And you have a built-in support system through your peers in this class. Y'all will get through it. Whatever it takes, y'all will get through the semester. You will be supportive of one another. Anybody else? Okay, I'm moving on unless I hear something from somebody. Caregiver role strain. I've talked about caregiver role strain many times in my classes. Caregiving. Let's move it on. Situation in which a lay individual provides direct care to another individual with a health-related condition. Your role as the nurse, depending upon the area where you take care of the patient, whether it's inpatient or clinic or home health, the caregiver and the patient, or the family and the patient, really become your unit of care. Common stressors with caregiving, just think about yourself. And if something happened in your family where you needed, it caused a change in the amount of time you have with school, with work, with whatever, how would that affect your ability to cope right now in what's going on in your lives? A change of roles in relationships. Maybe you may not have that supportive other, that parental figure. Maybe the husband or wife, girlfriend, boyfriend, there have been changes there. Juggling day-to-day activities with caregiving. They call a group of individuals at midlife the sandwich population. The sandwich is that you're contending with taking care of children and taking care of elderly parents too. Change in living arrangements. Anybody who got flooded out had to go find another place to live for a short period of time. And flooding is a big issue here in the New Orleans area. Lack of understanding of how much time it's going to take to caregive someone else. Do you have the financial means to have paid caregiving in the home while you go to work? Lack of respite or relief from responsibilities. Family conflict. Does it caregiving always on one individual in the family, or can it be divided up among a group of people? Being able to get your own needs met. Make sure you go for the dental appointments and the GYN exams and the general physical exams, or take care of these smaller health issues now rather than waiting until they get to be bigger. And inadequate information. And that's one of the things that nursing can do, is to, make sure your family knows how to really caregive for that patient. If you anticipate issues with caregiving when a patient is discharged, always think about a referral for home health. And I noticed President Biden is looking at, I don't know exactly what he's trying to do, but he wants to have more elder care, more home care, and caregiving, financial incentives, I guess, to take care of our elderly, which hopefully will be great for this group. All right. So as far as taking care of the caregiver, we need to make sure they take care of themselves in all the realms holistically. Look at their level, because if their health starts to decline, then we got two people that may be in need of health services. Linking the caregiver to resources, whatever that might be. Think about the population you want to deal with. What are the issues, the long-term effects that are going to happen with that patient and with caregivers? And what is out there in the community that can help them shore up whatever resources they may need? That is so important, guys. If you want to deal with neonates or, that population, there's a lot of emotional, social issues with grieving and loss and things like that for parents, and, that a loss, especially with a younger child, it can destroy that marriage or that relationship with one another. So I am finished. This is it, guys. I thank you for being participating, and I'll stay on for a period of time so that I can answer any person's questions.